Thank you, OPAI, for this opportunity to be a part of this wonderfully organized meeting. I'm going to introduce some of the features of congenital eyelid colobomas based on our 37 years experience with this condition. Since their description nearly 6 centuries ago, we have seen a plethora of cases described. We know that this entity occurs either because of abnormal migration of the ectodermal and mesodermal layers constituting the eyelids, or because of their mechanical disruption by amniotic bands or facial clefts. This implies a partial or total absence of eyelid structures. Most often in the upper lid, almost 2/3 of the cases in our series being the upper lid cases, and 1/3 being the lower lid. These may either be unilateral more commonly or bilateral less common. So the systemic associations which constitute a part of this are the first arch syndromes, we'll talk about them later, and the facial cleft syndromes. Golden hairs is probably the most common condition that we come across. The other being Treacher Collins, where we have the lower lid notches in the temporal part. The other facial clefts or other syndromes are often associated. So the cases that I'm describing are part of the largest reported series so far, where we reported 51 cases about a decade ago, but now have more than 70 cases, but this is describing 65 of those. Males and females are equally affected, and they may present as early as 3 days after birth to much later. The upper eyelid is involved in 2/3 of the cases, lower in 1/3. And golden hair syndrome at 13 cases is a very common association. And so is Treacher-Collins syndrome and the facial clefts. Most of the cases in the upper lid are unilateral, bilateral being only about 15 to 20%. All of them are located medially, varying from a small size such as a notch to almost 3/4 size in severer cases. The unilateral ones are mostly without exposure keratopathy at presentation, and only some of them are associated with exposure keratopathy, and most of these are the cases which represent symblepharon variant of cryptophthalmos with absent superior fornix and skin of the eyelid running on to the cornea. The upper lid colobomas bilateral are mostly with symblepharon variant of the cryptophthalmos and present with exposure keratopathy as we see in this patient. Some of these rarely are small notches, bilateral ones, and then they are without any exposure keratopathy. Management depends on whether exposure keratopathy is present at birth. A conservative medical management may be carried out for small defects or larger defects till we undergo surgery. Immediate repair is taken up in those with large defects with exposure keratopathy. In others, we prefer to wait till the age of about 3 years for the tissues to be more mature. Surgical management is based on the size of the defect, varying from direct closure to canthotomy, cantholysis, Tenzel's repair, or free grafts of tarsoconjunctiva and lid sharing procedures. The upper lid colobomas in our series were managed both with lid sharing and Tenzel's procedures, and those with absent superior fornix first had superior fornix created by a mucous membrane graft, as we can see here. Those without exposure keratopathy were operated later, and in these 23 cases, we did direct repair or Tenzel's repair. These being smaller defects are more amenable to procedures where lid sharing is avoided. Lid sharing was only done in older age groups or those with exposure keratopathy where we were not causing any further amblyopia due to occlusion of visual axis. Lastly, the surgical management of lower colobomas, unilateral being 14, those with clefts, and bilateral, those usually with the Treacher-Collins, unilateral being medial, bilateral generally being lateral. As you can see here, unilateral ones with clefts and bilateral ones on the outer side of the lower lid. These were generally small notches and could be closed by direct closure. Those with facial clefts required more elaborate techniques.
30 seconds.
Okay, direct repair was carried out in 8, and in unilateral one, direct repair was carried out in 6, but with some additional mobilization and canthal fixation in one case. The examples we'll see in the last few seconds. Lid colobomas are seen here. This is a coloboma repair was done along with the ptosis repair by bilateral fascia lata sling. This is a defect which has been repaired with a Tenzel's repair, which avoids the lid sharing procedure and visual axis closure, and the result can be seen here. So this is the pre-op and the post-op result.
Time.
Okay, last 30 seconds. Cutler beard procedure is used especially in those with severe exposure keratopathy, and we are able to improve the keratopathy by closure and get a good reconstruction of the upper lid. The last example is of a patient where we have a superior fornix defect as well and skin running onto the cornea with severe exposure keratopathy presenting at 2 weeks. We were able to do a fornix repair with a mucous membrane graft, taking it from the lip. And then we were able to do a tarsoconjunctival flap from the lower lid and release the flap after 4 weeks to get a good correction with protection of the cornea, and the keratopathy was taken care of. Vision could be retained to the extent of almost 360 and the child is fine. So this is a lower lid coloboma closed by direct repair, and the last unusual one with a cleft where we had to do a mobilization and medial canthal fixation to do a closure. So the surgical results have been gratifying, complications are very few, and we finally remember the special considerations that we have poor laxity in children requires special attention. It is important to avoid occlusions, and grafts of mucous membrane, conjunctiva, or AMG are important. Because of proliferation of mucous membrane, AMG is probably the procedure of choice for the reconstruction of upper lid. Congenital colobomas can be managed well with the appropriate planning. Thank you. Thank you very much.
Thank you, sir. Thank you for this enlightening lecture. Now I'd like to invite Dr. Mukesh Sharma. He is RPC alumni and